everyone. My name is Ruth Wilcock, and I'm the Executive Director of the Ontario Brain Injury Association, and I welcome you to this webinar today. OBIA has been educating people in the field of brain injury for close to 35 years, and we are pleased to present this webinar series in collaboration with the Brain Changes Initiative, whose founder is Dr. Matthew Galati. Dr. Galati sustained a very serious traumatic brain injury in 2013. However, he was able to return to medical school and now is a fully licensed physician. Today, we are pleased to have Dr. Adrian Owen as our presenter. But we could not do this without our sponsors, and it is my privilege to introduce to you now Patrick Brown from McLeish Orlando. McLeish Orlando has been a wonderful support of OBIA through the years, and I'm pleased to introduce Pat, who is a wonderful representative. In fact, Pat and I just recently were on a round table with the ministry around a bill called Moving Ontarians More Safely, Bill 282. Thanks, Pat, again for sponsoring, and I'll leave it to you to introduce Dr. Owen.
Perfect. Well, thanks so much, Ruth. And I did want to express my sincere thanks to you and OBIA for all your work doing and changing the laws, such as the one you mentioned, and as well, both Ruth and I, she didn't say, but we'll be in front of the government tomorrow supporting that bill and also trying to get changes to what's called a vulnerable road user law. OBIA has been one of at the forefront in trying to get these laws changed so that traumatic brain injuries are prevented and we don't see as many in the future. So Ruth, on behalf of so many different individuals and organizations, thank you and OBIA for doing your ongoing support on preventing injury. McLeish Orlando has been representing individuals with traumatic brain injuries and spinal cord, as well as other serious orthopedic injuries for over 20 years. We're so proud to support OBIA and Brain Changes Initiative. We've been privileged to have a long-standing relationship with you, Ruth, and your organization, but as well, Dr. Matt Galati, who we represented following his crash. And we're so proud that we can help and sponsor your organization as well, Dr. Galati. So firstly, thank you so much for everybody who put this webinar together, Terry and all the organizers. And we're so happy to be here and be able to introduce the keynote speaker. I'm very happy to introduce Dr. Adrian Owen. Dr. Owen will be speaking on what many will see as a timely and highly relevant topic that has come out in the last obvious year. And that's on cognitive and neurological consequences of COVID-19. And it's certainly a topic I've not heard much about at all. And I'm excited to hear it today. I personally have had 3 clients who suffered trauma during this time, and 3 of them contracted COVID following their traumatic injuries and have to deal with that on top of everything else. Dr. Owen is currently a professor of cognitive neuroscience and imaging in the Department of Physiology and Psychology at the University of Western Ontario. He also directs the Brain, Mind, and Consciousness program funded by the Canadian Institute for Advanced Research. He has also been on the executive committee of CFREF, and he funded the initiative of BrainsCAN at the University of Western Ontario. He was previously the assistant director of the Medical Research Council Cognition and Brain Science Unit at Cambridge University. He is the Canada Excellence Research Chair in Cognitive Neuroscience and Imaging at Western University. He's published over 300 peer-reviewed articles and chapters. He has a best-selling popular science book, Into the Gray Zone, A Neuroscientist Explores the Border Between Life and Death. Dr. Owen was recently awarded the Officer of the Most Excellent Order of the British Empire, OBE, in the Queen's Honors List in 2019 for all his services to scientific research. And we are so privileged and happy to have you today, Dr. Owen, in order to talk about this highly relevant and exciting, interesting topic that I think many of us have not heard much about.
Thanks very much, Pat, and thanks also, Ruth. Thank you very much for this introduction and for inviting me to speak today. I'm really honored and pleased to be here. As you say, I'm going to talk about some very recent research that we've been carrying out in my lab, looking at the cognitive and neurological consequences of COVID-19. I trust one of you will tell me if you can't see my slides right now. I hope you can. So, I mean, this is a project that obviously it is timely. It's only been going on since June of last year, but actually has a much longer and richer history than that. And because the results at the moment are still, they're still rather preliminary, I would say. We have a relatively small number of patients that we've studied. I'm going to tell you a little about the history, a bit about how we came to investigate this virus, why we were in a position to investigate this virus, and the tools that we've applied to try and understand both the neurological and particularly the cognitive consequences of COVID-19. So most of you, even if you haven't experienced this personally, you will have heard in the media about many of the primary neurological sequelae or consequences of COVID-19 infection. And of course, loss of smell is up there as the big one that everybody is talking about, but also headaches and aches and pains are things that most people that experience this virus, at least those people who are symptomatic, will have some of those symptoms. Less common, but nevertheless occurring in this population are other neurological signs like blurred vision, even strokes. We've seen an increase in strokes, particularly among younger people contracting COVID-19, seizures and delirium or very confused thinking. Now, an area that up until late last year really hadn't been looked at very carefully is impaired cognition, whether this virus actually affects things like your ability to concentrate and to remember and to solve problems and to perform reasoning tasks. And actually, it's quite odd that people like me haven't jumped on this more quickly, because so-called brain fog has been now described by patients going through COVID-19 and recovering from COVID-19 for many, many months. Actually, since the very beginning of the pandemic, people have started to use this expression, brain fog. It's sort of morphed more recently to include things like long COVID, where people talk about these symptoms, these cognitive symptoms, these difficulty with getting back to the way you used to be, that goes on long after the primary symptoms of COVID have subsided. Now, of course, as neuroscientists, brain fog doesn't really mean much to us. We've heard that expression before. It's often used in the context of things like chemotherapy. People talk about chemo brain. That's rather similar to brain fog. But it's not a word that really has much meaning in the neuroscience literature. And a question that immediately struck me when I started to hear this word being used, or these words being used a lot last year, was, well, we need to try and get to the bottom of this. What is brain fog? What are people really talking about here? The other question, of course, is why would people be experiencing these long-term consequences of COVID-19? I mean, this is primarily a respiratory infection. Why would it be affecting the brain at all? And really, there's two general answers to this question. One is that there might be direct effects on the brain, and the other are so-called indirect effects that I'll come to in a moment. Now, direct effects are exactly what it suggests, that the virus actually attacking brain cells directly. And I can say that I think at this stage the jury is still out on whether this is the case or not, though I think it's becoming increasingly likely that at least in some cases the virus can have direct effects on the brain. This is from a recent review, and there's been several that have been published in the last few months. This came out in February, and I've just highlighted the broad conclusion there, which is that COVID-19 infection can inflict acute neuropathology in susceptible patients. Much remains to be understood, including what viral and host factors influence brain invasion and whether it's cleared from the brain subsequent to acute illness. I mean, this is not entirely uncontroversial. Not everybody agrees with this, but I think we are moving in the direction of realizing that COVID-19 has a direct effect on the brain. What I know more about, and what I'm going to talk about more about today, are so-called indirect effects. many people, when I talk to the general public, many people say to me, well, this is a respiratory infection. What do you mean by indirect effects? And any illness that affects the flow of oxygen to the brain will affect brain function. Just because the effect is indirect doesn't mean that it can't be quite severe. I mean, outside of the pandemic, I spent a lot of my time looking at patients who have very serious brain injuries, who are vegetative or comatose. And many of those patients will have entered the hospital after a cardiac arrest. Now, cardiac arrest, well, that's a heart problem. That's not a brain problem. But actually, it's the same. It's the same as the issue with COVID-19. You have a cardiac arrest. It interrupts the flow of oxygen or the blood supply, and therefore oxygen to the brain, and this can cause brain damage. And the same could be true of COVID-19. That also, although it's primarily a respiratory infection, that does involve an interruption of the blood supply to the brain. And of course, there are other factors. We know that COVID-19 causes inflammation. It causes blood clots. Again, blood clots can affect oxygen to the brain. It reduces overall oxygen levels. But there are also other factors related to the more severe cases who become hospitalized. So we know, for example, that the sorts of sedation that are used to put people on a ventilator, these are incredibly strong sedative agents. They can also produce long-term cognitive consequences. Being on a ventilator is itself an interruption of the oxygen supply to the brain, and this can impair ongoing cognitive function. And in fact, a couple of years ago, we published a paper with colleagues here in London looking at ICU survivors. And we took a group of participants, a group of patients who'd come into the ICU, none for primarily brain problems. So these were people that were admitted for things like sepsis, cardiac arrest. They weren't there with a primary brain injury. Nevertheless, of the 20 patients that we followed, all 20 left the ICU with ongoing cognitive problems. So simply being in the ICU, now we don't know exactly why that is. It could be due to the drugs that are used. It could be because many of these patients were ventilated. It could be simply the interrupted and lack of sleep. But the bottom line is, this is well known to most intensivists that very few people leave the ICU and make a speedy recovery. So these are some of the reasons why COVID-19 is of interest to people like me. And here's the big problem. As of today, over 150 million people in the world have contracted COVID-19, and that's over 1.25 million in Canada alone. It's 30 million plus in the United States. And that means that a year from now, if we don't get on top of this problem, we may have more than 150 million survivors who are experiencing cognitive problems that may affect their jobs and their ability to go about their daily activities. And that will create an enormous economic and societal problem, perhaps one that is as big or bigger than the pandemic itself. Now, I count myself as being very lucky. As I say, I mean, typically, I'm not a COVID-19 expert. It's not, virology is not my area of expertise. I'm a neuroscientist. I've done a lot of work on brain injury and cognitive assessment. But it turns out that I was in a very good position to take on a large-scale study of the long-term cognitive consequences of COVID-19 when the pandemic hit. And that's really a 30-year story that I'm going to try and collapse into the next 6 or 7 minutes or so. So something that's been developed in my lab over the last 30 years now is a platform that we call Cambridge Brain Sciences. And this is a cognitive assessment tool. It allows us to measure things like memory, attention, concentration, reasoning, problem solving, planning, many of the sort of everyday cognitive activities that get us through our lives. Now, this is, as I say, it's a 30-year project for me. I started it doing my PhD back in the UK, and actually, I'll move on. I'll prove that to you. There's a picture of me in 1998 as a young PhD student in the UK, and that's where I first started developing these touchscreen-based cognitive tests. Now, it's hard to believe that 30 years ago we had touch-sensitive screens. We did. They were rather rudimentary compared to sort of iPads and the sorts of tablets that we all have today. But our idea back then was, well, can we move away from standard paper and pencil tests that cognitive scientists and neuropsychologists use, and develop something that's computerized. The reasons for doing that were that we wanted to make things more accurate, we wanted to make them faster, but mostly we wanted to make them more sensitive to brain injury or to specific types of brain injury. And the way we went around about doing that was by locating and assessing patients who'd had particular had damage to particular areas of the brain. Now, up until, I mean, just to give us a little bit of history, up until this time, this was 1988, I started this project, much of the development of cognitive tests had been based on not on the brain at all. I mean, back in the sort of 60s and 70s, we really knew very little about how the brain was organized. It was based on performance measures, trying to work out how quickly people could do things like sort cards or order letters and these sorts of things. And around the late 80s, early 90s, we started to get on top of this of understanding the relationship between brain regions and networks of brain regions and particular types of cognitive performance. And what I would do, back in the day is visit patients, and you see here a patient with a scan of a patient with a large frontal lobe removal, frontal lobe damage. And I would test these patients on the task and find out what it is that they couldn't do, what it is that they were impaired at, go back to the lab, tweak the test to make it more sensitive to that to damage in that part of the brain. And then I would go and find another patient who had damage to a different part of the brain and tweak a different test to try and make that more sensitive. And what you're looking at here is the modern version of what we call our token search task that turns out to be particularly sensitive to damage in the dorsolateral part of the frontal lobe, the frontal and upper part of the brain. Now, around 1990, I've been very lucky in my career. A lot of it is down to serendipity. Another thing that happened in 1990 is that functional neuroimaging, brain scanning, really came online and went sort of mainstream. And I was in exactly the right place at the right time. I came out to Montreal and spent 3 years at the Montreal Neurological Institute training in brain imaging. And I took the test that I developed with me and put healthy people into brain scanners, had them perform the task, and I could use that to work out, again, which parts of the brain were responsible for these particular tasks. And again, we would tweak the tests from year to year to try to make them specifically sensitive to particular parts of the brain or networks of brain regions. And again, here you can see on the right-hand side, there's activity or activation in the dorsolateral frontal cortex when a healthy person is carrying out this particular memory task that we developed. And the upshot of all this is that the Cambridge Brain Sciences platform was born. It's run out of my lab. And it's actually now been spun off into a commercial company that runs out of Toronto, employs about 35 people. Over 10 million tests have been taken. One thing that we've really focused on trying to do is to make the tests, and this is really important, and it's become important for the COVID project. How can we make the tests so that people can self-administer? How can we take it out of the hands of a neuropsychologist, so you don't need an expert sitting beside you? Can we get accurate self-assessments? And the answer to that is yes. We've done a lot of studies comparing the lab-based assessments with home-based assessments, and we're using different platforms. It runs on any internet browser. The retest reliability is excellent, and it's now appeared in more than 300 peer-reviewed scientific studies. Not all, of course, from my lab. Many people around the world, many other neuroscientists have taken these tests and use them, in different contexts to assess different populations and their cognitive problems. I've talked in a very abstract way about the tests. Here's an example of one of them. You can see somebody performing the test there. This is our odd one out test, which assesses reasoning ability. The idea is to look at these 9 shapes and simply identify which one is the odd one out. Don't get too excited. This is a really easy problem you're looking at here. And this is how the tests work. They start very simply. And then if you get them right, they very quickly get more difficult. If you get them wrong, they'll start to get easier again. And that way we can very quickly work out exactly what somebody's ability is. It isn't quite precisely. You can see the problems are already getting quite difficult for this person. And this is the way that we make the tests very short. And again, that was extremely important for our COVID study, because any big study where you're assessing members of the public, you need things to be obviously extremely reliable and valid, but also you can't keep people sitting around for 3 hours doing a cognitive test. You need to get it done very quickly and as accurately as you possibly can. So we've really developed a number of methods to make the tests very quick to administer. And as I've said already, they can be administered by people in their own homes. One more piece of background. I mean, these tests were developed long before the World Wide Web existed, but once the web became available, I put the tests up on the web so that anybody around the world could access them. And what that allowed me to do, and again, this is absolutely crucial for allowing us to do the COVID study, is it allowed us to recruit members of the general public for our studies. And we've done many, many studies like this over the years. And these are just two examples. In 2010, we recruited 11,000 people to test some of the claims about commercial brain training software. And the idea here is that we got all of the participants to assess themselves using Cambridge Brain Sciences, brain train using a commercial brain trainer for 6 weeks, excuse me, and then test themselves again. And we looked at whether there were any differences. And many of you won't be surprised to hear that there weren't. The commercial brain trainer didn't make any difference to healthy people's level of intelligence, if you like. That was published in Nature. An even bigger study came out in 2012, and here we were again looking at aspects of human so-called intelligence, measures like IQ. Do they really capture people's cognitive performance? Now, this is a record breaker for us. We tested 44,000 people in a little over 2 weeks. And you have to realize that, that's the sort of thing that one couldn't possibly do in a web-based setting. And that's really why I'm attracted to doing science like this. I didn't develop tests just so that we could use a computer rather than use a paper and pencil test. I like to develop tools that can be used to answer scientific questions that you could not possibly do in the lab. And obviously, for economic and logistical reasons, you could never test 44,000 people, but we managed to do it in a little over 2 weeks for a few cents once we obviously set up the system. Here's another example that will be, I think, interesting to this audience. It's a study of concussion that we carried out a few years ago. And again, I think it shows you the power of these online cognitive assessment platforms. So we put out an appeal across Canada for anybody that had sustained a concussion at any point in their life to log in and do the cognitive tests. And as well as people who hadn't sustained any concussion, so that we had a good control group. And we had many, many thousands of people log in because, of course, we all know that many thousands of people have had a concussion at some point in their life. We didn't know much about these concussions because, of course, we don't have people's medical records. But this is public science. And when you have large numbers, when you have tens of thousands of people, you can address questions that you couldn't do by examining everybody's medical records because you just simply couldn't get enough people together. So in this context, what we did is we got anybody that had been concussed to tell us how many concussions they'd had and also to perform the test. Now, the good news is that generally the concussed group were not impaired versus the non-concussed group. Now, remember, mostly this is not going to be acute concussion. These are going to be people that may have had a concussion a month ago, a year ago, 20 years ago. It didn't matter to us as long as they'd had a concussion. But the bad news is that on one test, and you can see it on the left-hand side, there was a profound impairment. And this is a test of inhibitory control. Inhibitory control is extremely important in everyday life, from deciding whether you should run that amber light at a crossing to whether you should respond to somebody in a bar that decides to pick a fight with you. There are many, many aspects of everyday life that involve inhibitory control, and that is us inhibiting our prepotent response, the thing that you might naturally be drawn towards doing. Yep, I can make it across that amber light, but most of us know that it's a lot safer just to pull up and not do it. So the interesting thing was that people who had a concussion were impaired on our test of inhibitory control. And I'm not going to we weren't content with leaving it there, because what we did is we then said, okay, well, let's make specific prediction about this result and go and test another population of individuals and see whether we can see the same thing. And the idea here was not to look for people who had been classically or clinically concussed, but just to examine a group of individuals who routinely sustain impacts or blows to the head. Now here we approached the varsity football team here at Western University, and for 3 seasons we followed the players, looking at who was concussed, the number of concussions that it had, the types of injuries that had caused these concussions. But the most important point is that we didn't wait for somebody to have a concussion and then test them to prove our hypothesis. We just said, well, as a group, these people are sustaining head impacts, whether they count as clinical concussions or not. And as many of you all know, by the time they make varsity football team, these players have played for about 9 seasons. Many of them are receiving hundreds of blows to the head in a given season, whether or not they cause a concussion. So our prediction was that this group, even though, whether or not they were clinically concussed, would show a similar pattern of impairment to the general public who we knew had been concussed. And it's surprising. I mean, there are 12 tests in this battery, but they showed exactly the same pattern. That is that the varsity footballers across the board were generally not impaired. They didn't have memory impairments. They didn't have reasoning impairments. Many things they were just as good as their, we compared them with a group of varsity rowers, so another group of elite sports people, but who don't typically sustain impacts to the head. And amazingly, again, they had this impairment in this one test of inhibitory control, the thing that prevents you from jumping in and responding rather impulsively when in other situations you might not. So that's my final example of how we use this battery to both engage the public in our science, but also to ask very specific questions like, is football, varsity football, are there any cognitive consequences associated with head impacts from varsity football? Let me now turn back to the COVID study. So this is where I was back in May or so of last year, and people started to knock on my door and say, well, this COVID, people are now complaining of brain fog, or they can't think straight. You should really get involved here. You're a brain guy. You've assessed cognition over the years. And my first response, well, no, this is not really time for people like me. We need to concentrate on vaccine development and tracking and tracing people and, testing and all these sorts of things. But as things rolled on through last summer and things started to accelerate, and I should say at the point that we launched this study, there were 8 million people in the world that have been diagnosed with COVID-19. Of course, we're now, as I said, more than 150 million. So things have absolutely exploded since then. And it became more and more obvious that there was something important to start looking at here. So I've given you the background. We had the tools available. I didn't have to develop anything. We had this fully functioning cognitive assessment website. It had been optimized for people to test themselves at home. Of course, with COVID, it's complicated testing patients because of the possibility of contracting the virus as scientists. So it was perfect in that sense. We could recruit people remotely. We could contact people anywhere in the world, so absolutely anybody could be involved. We had French and Spanish versions freely available already. The platform is entirely freely available. So we were right there and ready. And I had colleagues, Rick Schwartz, particularly at Sunnybrook Hospital, got in touch and said, let's do this together. Colleagues at University of Toronto and back in the UK at Cambridge University, Professor Menon, an intensivist in Cambridge University. The 3 of us got together. Kindly, we received funding from CIFAR. As was mentioned in the introduction, I run one of the CIFAR programs, and we received some money from a donation from Manulife and CIFAR to run the study. But we were up and running in a matter of weeks. It was literally just a case of getting the ethics permission to run the study. And the idea, these are some of the key questions we set out to address. Does COVID-19 infection result in significant cognitive impairment? And if so, what cognitive domains are most affected? And that's really unpacking this concept of brain fog. What is brain fog? Is it memory? Is it concentration? Is it reasoning? Is it problem solving? And that's really a question about cognitive neuroscience. Another question that many people are asking, well, is the burden of cognitive impairment greater in those who require an ICU stay versus those hospitalized outside the ICU versus those in the community? Put simply, do you have to have severe symptoms to have ongoing long-term cognitive consequences? Is it possible that even asymptomatic people have this problem too? Is it only those who are ventilated or sedated? It goes back to my original comments about indirect effects of the brain. Is it the effects of ventilation or the effects of sedation that are causing these problems, if they're there at all? And this is the big one that we're still looking at. And there are really three scenarios here. I mean, people clearly, I mean, you're not going to be surprised when I give you the results, the early results of the study, but I mean, people are clearly having long-term cognitive problems, brain problems with when recovering from COVID-19. And really there are three things that can happen in the long term. One is that, these problems are permanent. They don't go away. You've got them forever. The other problem, the other scenario is that they get better over time. Maybe it's something that only lasts a month or 2 months or 3 months and it gets better. The worst case scenario is that they might actually get worse over time. And I'm not suggesting that is what's going to happen, but there are certainly circumstances in which one might imagine, for example, a sort of the initiation of a neurodegenerative cascade that could result in, at least in some patients, in problems that begin with the infection and then initiate a deterioration over time. And that's something, so we're going to follow every patient in our study for a year or more, in the first instance a year, and try and understand whether they're getting worse, better, or staying the same over time. And of course, because we're online and because people have time to answer questions, we ask 60 or 70 questions of every participant. So we know a lot about things like their sex, their age, their medical risk factors, their background, and the experiences they've had. And we can use that to look at how some of these factors interact with the COVID infection. These are just some of the, just give you a flavor of how the study has been run. We had a very extensive sort of medical questionnaire at the beginning. We asked people about the symptoms that they'd experienced. Obviously, they rated whether they'd been in hospital, whether they'd been ventilated, whether they'd been asymptomatic. The neurological symptoms, things like loss of smell, we noted that. We're still unpacking some of this data because we have a huge number of different factors involved here, but I'll tell you about a few of them. We then went on to ask people about their pre-existing conditions. This is something that you'll read a lot about in the news. Lifestyle choices, whether people are heavy smokers, drinkers, whether they take recreational drugs, again, to look at whether any of these things factor into the outcome, as well as, of course, things like depression and anxiety. Heard a lot recently about mental health consequences of COVID-19, or indeed of being in the pandemic in general. And it's important that we get a baseline assessment from people and work out what their levels of depression and anxiety might be. So we use standardized depression and anxiety questionnaires. And then, of course, people did the 12 Cambridge Brain Sciences tests. Now, I'm only going to present data today from about the first 500 or so participants. We've had many thousands of people have participated. The reason I'm going to talk about 500 is because something that became apparent very early on is that people weren't being tested back in May and June of last year. Very few people were actually being tested. So it was impossible retrospectively to know absolutely that all of our participants had COVID-19. And I'm sure you can immediately see why that's a problem. Some people may not have had it, but had a bad cold or the flu and thought they had it. And of course, that's going to contaminate our sample. So what we've done here, and this is for the paper that will be coming out soon, is we focused on the 485 participants who had been tested, who had been tested and had been tested positive for COVID-19. We had a much larger sample of participants who had not had COVID, had no symptoms, hadn't had COVID. So we had a large sample to compare it to, but 500 in the first instance. And you can see here the breakdown. I mean, it's not very informative as you go down this list, but about 94% of the people that had been tested had symptoms. 6% had been asymptomatic. About 13% had actually been to hospital. The vast majority, 86%, hadn't made it into hospital. We asked questions like, were you mostly able to go about your daily routine? Did you sort of carry on life as usual with COVID, or were you restricted? Were you bedridden, whatever? And about 27% were able to, but the vast majority weren't able to sleep normally, work normally, continue with their activities and so on. And these sorts of questionnaires enabled us to relate people's responses to the World Health Organization official designation of COVID severity. And this is a 7-point scale. It goes from 0 to 6. 0 is you have no symptoms and you don't end up in hospital, and you basically are completely fine. 6 is obviously the worst case scenario. You're in hospital, you're in the ICU, and you are ventilated. And here you can, on the right hand side, you can see our distribution. Most of our participants, by far, at least from this early sample of 500, are there at number 2. They have symptoms. Daily routine, was affected, but they managed to stay out of hospital. Nevertheless, we have enough people to look at the effects of being in hospital. Everybody with a 3 and above was in hospital, and some of these people, even 15 of them, were even in the worst case scenario. They were hospitalized, ventilated, and in the ICU. So we can start to look quickly at the severity, how the severity of COVID infection impaired performance. Now, first, I'm going to tell you about our subjective outcomes, because we're very interested, and this is a really sort of important tool that cognitive scientists use to sort of understand exactly how things like, any form of brain disorder affects people's perception of their situation. It's really important to get both objective and subjective measures, because obviously many people might feel that they're impaired when objectively you can show that they're not, or even vice versa. So we subjectively asked people about their memory. We said, well, rate your memory now compared to how it was prior to COVID-19 infection. And as you can see, there was a very clear relationship between people's subjective ratings of their memory and how severe their COVID-19 infection was. The worse your infection, the worse you will report your memory as being relative to how it was before. But perhaps that's not a huge surprise. But it does show that people clearly feel that they are much worse, and it's related to the severity of the disease. And that's going to become important for the conclusions I'm going to draw in 10 minutes or so. The other thing, anxiety and depression, were also related to the severity of the disease. The more severe your COVID infection, the poorer you scored on standardized levels of anxiety and depression. But what about, so how did that, I'm just going to really get to the real crux of the main part of the data here and tell you how we've analyzed this. Now, what we did is we took all of these factors, all of this information that we had about people, and these, what you're seeing around this circle, are various things that people answered questions about. Down the bottom, you see subjective memory. That was, is your subjectively, is your memory back to where it was before? Cognitive function in general, do you feel you're cognitively back to normal? Physical functioning, did COVID-19 affect your ability to function physically in the world? Has it produced any physical limitations? These were all things that we managed to derive from the questionnaires. Has it left you in any pain? The anxiety and depression, of course, were measured objectively with our questionnaires. Fatigue, are you fatigued? And what we found, that what this circle represents is the relationship between these different factors. And we used a relatively complicated statistical method known as independent component analysis, where we tried to look for patterns in the data. Are any of these things actually related to one another? And it turns out that there are 2 strong patterns, and that's represented by these rings on the outside. And one of these patterns, represented by the inner ring, I'm going to call physical symptoms. And that's just, that just suggests that all of these different components loaded on that factor, they were all strongly related to another. And the relationship between between people is represented by these colored lines, but running across the circle. So unsurprisingly, let's say physical functioning, how you related your physical functioning is strongly related to whether you experience any pain or not. Those are both very physical things. Physical limitations, whether you had physical limitations, again, it's strongly related to physical functioning. Fatigue is strongly related to physical functioning. But things like, say, anxiety, for example, is not at all related to your physical limitations and your physical functioning. So there's one factor represented by the inner ring there, which really groups all these things together, and that's physical functioning. How physically, or how did COVID-19 affect you physically? The second factor, represented by the outer ring, and you should be getting used to this rather complicated diagram now, I'm going to refer to as mental health symptoms. And it doesn't matter about the colors here, it's the intensity of the color that's important. And here you see, anxiety and depression are very strongly related to one another, but also part of this outer ring of mental health symptoms. So are how people related their emotional limitations, but also their subjective measures of things like, things like baseline cognitive function are both related to physical and to mental health. But the main point is that there are two different outcomes here that are sort of dissociable. That is, their physical symptoms and their mental health symptoms. Now, we know they're dissociable. When we went back and looked at the data, we found different ways of confirming that these are two different potential outcomes of COVID-19. And by that, I don't mean that you have one or the other. You can have both, but they are separable. And that, for us as neuroscientists, means that they probably arise through different direct or indirect brain mechanisms. And here's another piece of information that'll tell you how we know that they're different. Physical symptoms, you won't be surprised, are strongly related to your age. The older you are, the more severe the physical consequences of having COVID-19 will be. The younger you are, the better able physically you are to cope with the disease. Mental health, though, goes actually in the other direction. The younger you are, the more likely you are to suffer from anxiety and depression after COVID-19. The older you are, the less likely you are to have these mental health symptoms. So, in fact, the physical and mental symptoms go in the opposite direction as far as their relationship with age. And that, again, is an important clue that tells us that these are two different pathological consequences of COVID-19. Again, I don't want you to go away thinking you'll get one or the other. You could have neither, you could have both, but they're dissociable. You could end up with just having physical symptoms and no mental health symptoms. You could end up having anxiety, depression, fatigue, and other sort of more emotional problems, and very few physical symptoms. But what about the cognitive data? And this is the real sort of take-home message that I want to leave you with today. Across our battery of cognitive tests, and this is an impossibly complicated couple of graphs, but I'll explain it to you very simply. F1 and F2 down here are these two factors, the physical factor and the mental health factor, F2. We broke down the tests very broadly. I'm not going to report on all 12 of the cognitive tests, but we talk about them in terms of whether they involve short-term memory, reasoning, verbal abilities, processing speed, and overall cognitive function. And what's important are these three stars here. And that shows you that, well, on the one hand, short-term memory is not affected by COVID-19 at all. And this is interesting, that a bit like concussion, a bit like lack of sleep, we've shown in a recent sleep study, not everything is impaired. Brain fog doesn't impair every aspect of cognition. It turns out that your memory is relatively spared. People are not, even though they say their memory is impaired after COVID-19, objectively, that doesn't appear to be the case. People's memory seems to be rather resilient to the infection. However, things like their processing speed, how quickly they think, and also up here, their reasoning ability, their ability to solve simple problems, verbal ability and overall cognitive ability are strongly associated with the physical symptoms of the disease. So if you look over here on the right-hand side, reasoning ability is again, and this is just a measure over here of how severe physical health was, from poor health to good health. physically, reasoning ability is strongly associated with how physically affected you are, as is our verbal tests, our verbal tests here, and tests of processing speed, how quickly people think. The most surprising and interesting thing for me is that mental health was completely unrelated to any of these factors. And typically when we think about mental health, I think people often bundle things like depression and anxiety and these aspects of mental health alongside things like cognition. It's all stuff that affects your brain. So it's very interesting to me that these two things are completely dissociated here. It doesn't, how depressed or anxious you are does not dictate whether you will have cognitive consequences of COVID-19. These things are totally dissociable or separable. Again, you could have one or the other, but you could have, so you could have both, but you could have one or the other too. So my take home here is that that there are cognitive sequelae of COVID-19 infection. Absolutely clear that we saw profound deficits. The level of those deficits are very similar, I would say, to a sleep study that we conducted in 2017 of about 20,000 people. And there we showed that profound lack of sleep was associated with a pattern of cognitive impairment. And the level of cognitive impairment in our COVID-19 survivors is at around the same level. It's like people who are severely sleep deprived or have suffered a lack of sleep over a prolonged period of time. But the other really important message is that this is something that is related to the physical symptoms of the disease. The worse you are affected physically, the worse your cognitive outcome will be. Now, there's a little nuance I'll add to that, which is that this is not just about hospitalization. It turns out that these effects were seen even in people who were not hospitalized, in people who were not sedated, in people who were not ventilated. So it's not about being in the hospital, having the most severe clinical interventions. Even people that didn't get into hospital still have long-term cognitive consequences, but it is nevertheless related to the physical severity of the disease. So three broad conclusions here. Two factors characterize people's questionnaire responses. One was mostly comprised of physical symptoms, and the other were relating to mental health symptoms like depression and anxiety. Objectively, cognition was related to the physical rather than the mental health symptoms. So the worse your physical symptoms, the worse your cognition. And that wasn't true of the relationship between mental health and cognition. So as I've said already, and I'll just summarize here, there are two types of COVID outcomes. One that primarily affects physical health and one that includes cognitive deficits. One that affects physical health and involves cognitive deficits, and another that primarily affects mental health or aspects of mental health like anxiety and depression. This is an ongoing study. What I've shown you really is what we knew of our first cohort of participants at the 3-month point. We're now well past the 6-month point with these people, and if you invite me back again, I'll report on the longer term consequences. All I can tell you at the moment about that is that from the questionnaire data, where we asked people how long ago they'd received their positive COVID test, there was no relationship between the severity of cognitive deficits and how long ago it was that you were diagnosed with COVID. Now, that could mean two things. It could mean that, the good news is it could be that things aren't getting any worse over time. It could also mean that things aren't getting any better over time. But we'll only really know when we have the full longitudinal data to back that up. So this was a collaborative effort, as everything I do is. Rick Schwartz at Sunnybrook Hospital, David Menon in Cambridge, I've mentioned them both already. Connor Wild, who works in my lab, did absolutely most of the heavy lifting on this study. He's done all the analysis and written the paper. We also had a lot of help from Loretta Norton, who works here at Western, David Ripsman, a a clinician at Ottawa, and as I said, it was funded by CIFAR, the Canadian Institute for Advanced Research. Some obviously none of the COVID. My book came out in 2017. It was kindly mentioned in the introduction. It's called Into the Grey Zone. It's available in probably 15 different languages now. It doesn't detail the COVID study, of course, but it does give a lot of background as to how we got ourselves into a position to be able to carry out a study like that. So if you're interested in that, if you're interested in the cognitive assessment, it's not a science book. It's more of a scientific adventure, I think. It's a story that involves patients with brain injury, and the stories of the patients, the challenges they face, how we've investigated them over the years, involved them in our research, and some of the more interesting discoveries that we've made over the last 30 years or so. So thanks very much for listening and for dropping into this webinar. I'm very happy to answer any questions.
Hi, Dr. Owen.
Hello.
How's it going? I just wanted to thank you for giving such an interesting and relevant presentation. I'd also like to say that I was a Western grad, so go Mustangs. So to introduce myself to the audience and Brain Changes, I'm Dr. Matthew Galati. I'm the founder of Brain Changes Initiative. We were founded back in 2019, and it was largely inspired by my own rehabilitation and recovery from TBI. Our mission is to raise funds for groundbreaking research to help change the standard of care for traumatic brain injury. We also serve as an avenue of awareness, education, and support for traumatic brain injury patients, their families, healthcare providers, and people who just want to live a brain healthy lifestyle. So please follow us at Brain Changes on Instagram. I'd also like to mention that we are extremely honored to have partnered with OBIA in bringing to you guys this webinar series. You guys are doing amazing work in the field, and we commend you for that. And I'd also like to thank our sponsor, McLeish Orlando, for not only sponsoring the event, but also for all of your amazing support around my own rehab and recovery. So Dr. Owen, there are some questions, and without further ado, so first question, did you identify people with pre-existing brain injury in your study?
No, we didn't. That's a great question. We didn't do that. We did ask people a lot about their medical history. So I guess in a sense we did. They had the opportunity to tell us about that. We didn't specifically, exclude people, but historically we found that's one of the advantages of doing these large-scale studies that involve, many members of the population, that we can accommodate everybody, because, as everybody listening to this knows, there is no normal. All of us have had different experiences in our lives. Many of us have had brain injuries or been involved in activities that might have affected our brains. And for us, it was important to take a snapshot of the general population. So I'm sure there will be some participants in the study who had pre-existing brain injuries, but of course it will also be important to look at how that affect, whether COVID-19 affects them differently. So this is all important information for us.
Thank you. So second question, regarding the concussion study, did you ever control for baseline impulse control?
Regarding the concussion study, baseline impulse control? No, and that's no, we didn't. But I don't think that's a problem for two reasons. I mean, it might be a problem, and I perhaps shouldn't say this to you as a Mustang, but as a former Western grad. But I mean, there is a school of thought that people that go into activities like football that they know are going to involve a lot of head impacts may have a problem of impulse control to start with. That may be the reason why they get involved in more risky things. And of course, that is a potential worry about our study. On the other hand, that doesn't account for the deficit in the general population, right? And the important thing there is that I didn't mention this when I was talking, but the people that volunteered didn't know that this was a study about concussion. In fact, it wasn't a study about concussion. It was a much broader study about the effects of lifestyle factors on cognition. There were several questions in there about concussion. So we wouldn't have particularly, it wouldn't have been people that were particularly interested in concussion that would have gone after the study, because it's not until you get partway through that you realize there are any questions about concussion. But, you know, of course, there is always the possibility, and, you know, I acknowledge this, that, you know, people who have had a concussion may have had, or may be more likely to have had that because they have a problem of impulse control to start with. I think it's a bit of a long shot when you're talking about the general population, because of course we know that many people have a concussion for reasons that were completely beyond their control. So, you know, I think in the broader population, that's very unlikely to be an issue.
Good answer. And last question. Do the self-administered cognitive tests need any clinical interpretation, or does the patient get results of problems?
That's a really great question. I'm glad you've asked it. Yes, when we started, so typically depends. It depends how you subscribe. And I put it in the chat there. Anybody that's interested in these tests can check them out. They're at cambridgebrainsciences.com. They're free to take. You can sign up, do them yourselves. Depends how you do it. Depending on the sort of study, how the study is set up. So in the first instance, we didn't give people feedback because we didn't want that to influence how people behaved. But very quickly with this population, the COVID population, it became really apparent that people wanted to know whether COVID-19 had affected their brain. And it felt to us like it was unfair to not let people know. They were giving up to an hour of their time. And if anybody here has had COVID or even hasn't had COVID and wants to contribute to the study as a control, it's at covidbrainstudy.com. It's sort of attached to the Cambridge Brain Sciences website. And so yes, the shorter answer to the question is yes, we do give people a full readout with an interpretation of their results. It's obviously automated. It's not done by a person sitting looking at every results. But when you have a database of 10 million people, we can do some pretty amazing things. Like, for example, you know, I'm a 54-year-old British male. If I want to, if I input that data into the study, we're able to compare my performance with every other 54-year-old British male that's ever taken these tests. So we can get really focused, demographically matched groups for each participant, and that's all fully automated. So when you log in and you do the test, it won't just tell you how you compare to a bunch of 18-year-old students. It'll tell you how you compare to people who are of your age and your gender and some aspects of your background. So it's tremendously powerful, and we have the general public and their contributions to thank for us being able to do that.
Perfect. So thank you for answering all the questions, and thanks again, Dr. Owen, for such an amazing presentation. And I will hand this over to Ruth.
Thank you so much, Dr. Owen. That was wonderful and in such a relevant topic. Thank you again, McLeish Orlando, for sponsoring this webinar. We couldn't do it without you, and I invite everybody to also view our other webinars. Thank you again.